Welcome to Inside Aesthetics, the world's leading podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor with over 16 years experience in facial aesthetics.
And I'm David Siegel, an entrepreneur and business mentor with over 20 years of experience in our industry. Our podcasts are aimed at industry professionals, and any information or advice given is general in nature. You should consult with a healthcare provider before undergoing any treatment.
You can also subscribe to us on Patreon for on-demand content for injectable and business education.
Hey guys, as you'll hear us referencing in today's podcast, we're evolving in a new direction, and from this episode, we'll start dividing some of our future podcasts into two parts. Part one of these episodes will continue to be free as usual, and these will be available as normal on whatever your favorite podcast app is. Part two, however, will be exclusively available for subscribers to our Patreon only, and these episodes will only be available on Spotify. You can sign up to either of our Patreon tiers and you don't need to pay for a Spotify subscription. Just download the app for free. For more information and a step-by-step guide on how to sign up, please read our podcast description. And Jake and I really thank you for your support.
Good morning, David. Back in the studio again, Wednesday morning.
Yeah, it is. It's my favourite time of the week.
I don't know about that. I'm sure there's better things to do than be with me for an hour and a half.
I don't mind it. I miss you. I miss you on those 6 days.
That's very sweet of you. How's it all been going? What have you been up to?
Busy. Always busy. I think that's what I say every week. Lots happening, lots of consulting with clients all around the world, talking to someone in the UK yesterday, a couple of people in Australia, just helping them with their businesses, lots of different factors making things challenging for people at the moment. But it's good. I get to get a little bit of a snapshot of what's going on around the world in different economies and, you know, different patient profiles and treatments that people are doing. So, yeah, it's super interesting. What about yourself?
Busy week this week. So I had a colleague, Dr. Iman Nerlin, shadowing me in clinic yesterday. She's come over from Sweden because it's the A24 conference this week in Sydney. Yep. So we'll be starting tomorrow, actually. It kicks off tomorrow. Mm-hmm. I'm chairing a polynucleotide sort of chat for about an hour, doing a bit of live injecting, and then I can relax for the rest of the conference and just enjoy.
What are you going to be injecting?
I'm doing periocular polynucleotides for skin quality.
So which product are you using for that?
Regeneration.
Okay.
Yeah.
Interesting.
So that should be fun. So it's just a busy week, as always, in our industry.
Absolutely.
Yeah.
And what's been happening with Patreon for you?
Patreon this week, I published some videos with a colleague, Dr. Jess. She joined me from Byron Bay last month, so she came down for the day. Yep. And she did a Profilo treatment on me. So we videoed my treatment, and we just spoke a little bit about neck indications, skin quality, why you use Profilo, and some strategies.
Excellent. I have recorded a very short video, probably about 10 minutes long, on just some financial analysis, which people find super boring, but a couple of things that we sort of went into in particular was how to calculate your break-even point every week. So why do you need to know about that? Well, most people look at their bank accounts, and that's the test that they use to sort of work out whether they're doing well or not doing well, which can sometimes be misleading. So knowing what you need to make every week so that you can keep your doors open and your business continues to be viable, and how to calculate things like your gross margin, because as we move forward in this sort of almost like global economy now, we've just got inflation running rampant across the world. So your rent goes up all the time, the cost of your staff go up all the time, all of your input costs, so your needles, your gauze, all that sort of stuff gets more expensive, and your margin will decrease, which means you're working harder for less money.
Yes.
And so being aware of what your gross margin is allows you to pull certain levers to make sure you're still making money. So whether you look at buying things more intelligently, whether it's time to increase your prices, strategies, how to do that. So this was just a quick and dirty explanation, taking a P&L and like, these are the numbers you need to look at. This is how you calculate it. Yeah. So you can actually start to become more financially literate and be working towards having a profitable business or maximizing its profitability.
Perfect. Now, if you're a new listener to the podcast and you don't even know what Patreon is or what we're talking about, Patreon is an app. So you download the app for free, and then you look for Inside Aesthetics on the app, and you can subscribe to our Patreon tier. Yep. That basically gives you access to all of the videos, all of the content, all of the stuff that we do. There's tons of stuff there. David obviously does the business stuff. I do the injecting, and people get a lot of value. We've got about 350 paid subscribers now. So it's growing really well.
Growing really well. well. And we're going to be trying something new today with Patreon.
Yes. We'll see how this works. We haven't quite planned this, but we'll introduce our guest, Dr. Ben Talei, first. But Ben is a plastic surgeon all the way from Beverly Hills. He joined us way back, I think 2021, on episode 173, where he talked about lip lifts and surgical indications when basically lip filler isn't enough. So we'll talk about Ben in a sec, but what we're going to do is try to divide this episode into two halves.
Yes.
First half is free. Go for gold. All of our podcasts up until this date have been free. But chapter 2 of this podcast, we're going to try and make exclusive for our Patreon subscribers. So if you like the first half and you're tempted to listen to the second half, watch out for the second half on our Patreon. We'll see if we can get the technical aspects of this working before this is published. We might have to edit this all and get rid of it. But, just for some, I guess, background, we've done a lot of podcasts. It's a lot of work, a lot of time and effort. And we want to get better guests, bigger guests, make this even more valuable to you. And that has to be profitable. So that's the reason behind it. It's not that we're money hungry and just abusing everyone. We actually have to make this viable.
Well, this went from being just a little fun passion side project to essentially like a part-time / sometimes full-time job. So yeah.
Anyways, so let's introduce Ben again. So Ben, all the way from Beverly Hills, how are you, my friend?
Fantastic. Thank you.
It's looking nice and sunny there. What time is it there?
It is 6 p.m. So it doesn't get dark in LA for a little while, which is nice because we got the swimming pool heated all summer long.
Oh, so nice. And what were you up to today? Were you operating, consulting? What was your day like?
Yeah, my Monday, Tuesday, Wednesday is all surgery, and it's mainly facelift. So it's usually 1 to 2 facelifts a day, and then throw in a lip lift, a nose, these kind of things. So just all that kind of stuff. And Thursdays are my consult days and follow-up. And then Friday is the day I spend at Cupid Lips, my lip location, trying to get everything going there.
Great. Well, so tell the listeners who maybe missed your first episode and maybe haven't come across your Instagram. So obviously you're a plastic surgeon. You've said your sort of your broad interest, but how did you get into it? Why did you get into it? And what's your sort of day-to-day sort of practice like now? Who are your patients?
I do facial plastic surgery. I trained as a head and neck cancer originally, and then went into facial reconstruction, and then went into facial cosmetics, and then did some pediatric plastic surgery and birthmarks, and moved to LA. And living in LA, everything went pretty rapidly in the direction of cosmetics, even though I was so heavily trained in reconstruction. My day-to-day for many years was 16-hour days, 6 to 7 days a week, doing half surgery, half injectables. So I got a big background in injectables and lasers, radio frequency. I was laser trained like a physicist, basically, for my birthmark fellowship. So I was very, very into that. And the injectable way of life made me really good at the aging face. So I really understood the face faster than most people. And in LA, I became very, I'd say, known for the type of facelift that I did, the type of lip lift that I did, and well known for the eyes as well, even though it's not something I heavily market. After a while, I gave up on the injectables. It was just ruining my life. It was too many people. I never advertised that I did it, and I was still seeing 20 to 40 people a day, 7 days a week. So that's after surgery, doing injections. So I was and it's not that I injected tons of volume into people's faces, but I was a very avid injector, and I couldn't sustain life like that anymore. It was too many people. So I canceled it out of my life, got 2 pretty much genius nurse injectors, a nurse practitioner and a PA, and they run everything for me now at the level that I used to. And then I focus now just on surgery, and not because that's all I like to do, but because just out of necessity. I was going to die otherwise, but I still do a lot of injectable teaching and teaching courses, and I teach very differently than almost everybody in the injectable realm because my experience is bigger than most of theirs in both surgery and non-surgical.
It's interesting that the whole concept of facelifts, because it's been something that's, I think from my perspective, and I could be wrong, just what I see here in Australian people I talk to, it's sort of one of those procedures that seems to come in and out of fashion. In some respects, people get very scared of the over sort of, I guess, over tightened, windswept or wind tunnel kind of look. And then there's been people like yourself, people like Dr. Giacono, who've sort of made it popular again and sort of looked at these techniques where they look more natural. They don't look like they've just had some sort of weird treatment done. So how's that trend sort of sort of come and gone from your perspective? And what is it now about the techniques that you're doing that sort of have, I guess, brought it back into fashion and made it something that people want to consider again?
It's become incredibly more popular, and the trend's always been kind of going in the positive direction, and it hasn't gone away. It's just that other types of treatments have come into play where certain people in a younger age find that, okay, you know what, there's something else that I can delay with before getting to it. But the popularity of facelifting has been increasing along with everything else. And especially with the more natural ways that we're doing it, and social media helping us portray that, because there was a pretty big major stagnation in facelifting for many years with the older surgeon types trying to keep the new things from coming out because they just couldn't achieve it themselves, and they didn't want, the business going elsewhere. It was very financially driven rather than academically driven. But now you see the facelifts look natural. And in fact, I have conversations all day, every day, including right now before I talk to you guys, with a patient saying, oh, so you pull the muscle, you muscle tighten, you do this and that. And I'm like, and I try to explain to them, I actually don't pull at all. It's done a different way now. And there's a reason people don't look pulled. It's because I don't pull. And that's the new way of facelifting, is finding that kind of sweet plane and position that you can go in and release the face with knowledge of that anatomy, where someone's laying on their back and everything just kind of falls back into place, anti-gravity. And that's the way that I do it. And that's the Auralift. It's kind of a term I coined for the name of the procedure, but it's just a gimmicky name. It's really just a very good facelift, and we can do it on younger, older. It's not really age dependent, so it's more kind of anatomy dependent. And even I'm able to do a miniature version of just the neck, where I can not remove skin, go in there and do something called a weekend lift, and get this like really big neck lift just from 3 incisions. And it's pretty impressive what we can do now, just knowing the anatomy better. I know the anatomy way better than I used to even 2 years ago.
Wow.
Yeah, I'm going to ask you about the anatomy and what you actually do in surgery. But first of all, why is America, and especially obviously Beverly Hills, why is it so cosmetically focused? Where did that come from? And do you obviously get high profile patients. Do you struggle with understanding what they have in their mind? Because, celebrity look may be different to your average look. And do you have to push back and say, well, that's just not reasonable or realistic? We're seeing it more and more in these sort of celebrity trends where people comment on what they had done. I mean, it drives me mad personally. I don't care. But why is that culture so common in the States?
Hollywood?
Well, yeah, but people want to look normal still, surely.
Yeah, no, I think cosmetic surgery is popular here just because people are ugly. Uglier here than most.
We're going to clip this. Clip that section.
No, it's actually a very good-looking population, and it's been popular for a long time in Los Angeles, quietly under the radar, where people had to get work done to maintain because they're in a youth culture. They want to look younger, look fresher. People, let's say you're like a supermodel and in your 20s and 30s, the world is obsessed with you. And then you start to see that life changes for you and you're used to being treated a certain way and recognized a certain way. And people really, when they look at you, they expect you to look like you used to look. You're a famous actress. You can't just let go if you were someone's idol and they see you walking down the street 200 pounds overweight, that you feel as though there's an obligation to maintain. So there's a lot of reasons why classically Hollywood has been like this. It's also where a lot of the plastic surgery started, just like Brazil. These were mainstay kind of places to come to have things done. So the popularity grew around here. Now, in the past 5-10 years, it's totally different. Now there's TikTok, there's Instagram, and there's a generalized acceptance of this where people do talk about it more and more. And it's also like you're saving faces, because there were these actors and actresses who were scared to talk to people about it publicly and would just go to whoever their friends told them about, and they'd go get destroyed too. So you have this face all over Hollywood by mediocre surgeons. Everybody goes and looks terrible. And you see this in Germany now, you see it in Sweden now, where there's really just a few really good surgeons here and there. And the majority of the population is scared to talk about it with their friends and with others. It's, it's got that bad stigma to it. And what happens to them is they end up going to surgeons who aren't as experienced, even though they have good surgeons in Germany and Sweden, but people don't want to talk about it. But you'll see the same trends happening at a delayed rate that happened here. So the same thing that happened here slowly is happening in London, slowly is happening in Italy and other places that they weren't so accepting of plastics. And the more that it happens, it becomes teams now where everybody is on the same team. They say, you know what, like I went through this process, someone else went through this process. I'm not alone. I'd like to share it. It becomes fun for them talking about it, and it popularizes it, more and more. And in many cases, of course, some people just never want to talk about it because they don't want the discussion of plastic surgery to be part of their lives. So you'll have actors and actresses deny it all day because they just don't want that discussion involved in their professional career and how they're perceived.
Yeah, I haven't seen you do this. Maybe you have, but what do you think about these surgeons who sort of break down celebrity surgery and talk about he did this, she did that, this is why she looks terrible? Like, do you think that's tasteful? Do you think it's good education?
Yes and no. I mean, it's a little tacky. Most of the surgeons do it because they kind of follow TikTok trends and YouTube trends. It's the average person, right? They're very average thinking and they can't think for themselves. And they say, oh, I want to get popular. How do I get popular? They abandon getting good at surgery. They just say, okay, let me do a bunch of videos and start dancing and do all these things to just get popular for, getting popular. Now, that being said, I'm probably a bit of a hypocrite because not that I'm dancing on TikTok, but when I was starting practice, I get interviewed by, InStyle magazine or whatever magazine, and they'd ask me, do you think this person had plastic surgery? And I'd look at it and, say, no, they haven't, or yes, they have. Now, I did that twice, and I didn't love being involved in it only because I realized, holy shit, I just did that actress's best friend. They're going to come to me and it's going to be embarrassing for me that I commented on them, even though it's correct. So I backed off on doing it because of that. So I don't judge anybody for doing it. I did it myself, but I myself currently am I feel a bit classier than that at this point. Yeah. Not that I was. Obviously I'm not beyond that, but I don't personally find an interest in doing that. And in some cases, if I look at somebody's photo before and after, I can't tell. And that's like, the best work ever, and that exists out there. Yeah. But there are a lot where I can definitely point out to you what they had done.
Fair enough. Now, you're a surgeon, but you've done injecting for a long time, but you've sort of dropped it. And I'm just curious to get your surgical kind of take on why our faces age. Like what happens to our face? Why does it get saggy? Why does it get droopy? Because it's a good starting point to discuss this topic that we're going to get into. And I guess, because we're dividing this into part 1 and part 2, part 2 is going to be more about, I guess, your take on what you think the implications of using particularly biostimulators in the face are. Because you've been quite vocal on Instagram where you think it's potentially negative and has an impact on surgery. So if we start with facial aging, and then we'll get into the meat of the topic in part 2.
Yeah. Well, facial aging itself is so complex. Nobody can tell you how the face ages. And surgeons tend to wrap their minds either around the kind of mystery of facial aging and where they get things wrong, and they don't know what things went wrong and why they can't improve somebody, or they fixate on 1 or 2 things that they can identify from an MRI study. And that's really it. Like they just, they saw a CT study or an MRI study, and there's bone resorption, and so they fixate on bone resorption the rest of their careers, or there's submandibular gland ptosis. They fixate on that because they have difficulty kind of seeing the face as a whole and understanding that there's this process going on that's beyond what we can understand. And this is a process that we need to embrace, not fight. And that's another big problem. I was doing a conference this past weekend in Newport, and this surgeon came up to me and she was telling me that the face should be 30% more here than here, and it should have this much volume, and it should. And I'm like, and I just told her to her face, I'm like, you have terrible taste, and you probably have worse taste than women. And she goes, I'm not into women. I go, thank God, because every woman you date would look mongoloid. I go, that's not natural. Like, we're not just making people. We're not sculptors. You have somebody who's aging. There's only so much you can do. You have to work within your little box, your little sandbox. You don't get to do everything you want. So when I look at facial aging, I understand that there's a lot going on. And I accept that there's a lot going on, and there's very few things I can understand about all of it. But there is dehydration in the face. There's water volume loss in the face. There is fat loss in various parts of the face. Muscle position changes. There's strain on the face, which occurs. There's fat loss in a layer that's above the muscles, which makes them, when you lose that, the muscles work harder because they have no resistance anymore. And this is something that only I talk about, but it's real. It does happen. And you have some bony changes, and you have gravitational pull and difference in tissue consistency over time, which means the tissues actually do have less rigor and they become a little bit more soft and lax over time. So when I'm looking at facial aging, I say, okay, what can I do for these things? Because I can't replace like for like. I can't reverse something. I can't reverse time. So what can I replace where no one will know that I replaced it? What can I restore position of that nobody will know that I did that? Like, it'll kind of look natural if somebody went in there, knowing that no surgery is natural. That's the way I approach it, accepting in my mind that as you get older, you should have a smaller face. You should have a lower volume face. I'm not going to fight that to the end of eternity. I'm going to accept it and say you should have a more delicate face. It looks ridiculous if you're 70 years old and you have the volume of a 20-year-old. It'll never fit. It'll never work. Too many things have changed for that to work. So overall, when I have a patient come in, I simplify it for them even more. Aside from the hydrational stuff, which is super, super important, but difficult to maintain, I say you have some volume loss in the face in different layers. We can try to restore some of it, not all of it. You have drooping, which occurs, part of it from inner laxity, part of it from gravity, and then you have skin quality changes, which happen. So I just give them these three realms of things, and it really simplifies it. And then they don't go chasing things. They're able to really focus on the three things that I can do. I can do, let's say, a facelift. I can do a radiofrequency skin tightening. Ben told me not to do too many of them or else it's going to make me worse, not better. And I can do some volume restoration. And he told me not to do too much or else I'm going to look like the mongoloid idiot. So these are the way, that I break it down. Now, we have to deal with aging now in a different way because we do have fillers now in play and biostimulators now in play and threads and radiofrequency and heat-based treatments. And they're not always done responsibly. So that's where, aging, we now have to look at it differently to say, how do we also help treat the acceleration of aging, which has occurred from all these other types of things, which, we all like to do.
Yeah, that's a good summary. I think it was a good point that you said that, we need to explain to patients that you are 50, you are 60, you are 70. There are only certain parameters that we can work within. At the end of the day, your tissue is never going to be the same as a 40-year-old or less. So it's worth, if you're an injector listening to this, to try and be a bit more explicit with your patients about the expectation. I think sometimes injectors focus on the technique and the product and not, talk to people more holistically. But do you think, as a surgeon, maybe you're a bit different because you were an injector, but do you think that we're limited by our own biases? So, surgeon's got a scalpel, he's got a tissue plane that he'll generally work within. And like you said, you tend to ignore the bone because that's not your realm, it's not your thing. Us injectors, we're led by our own biases and we're going to focus on other things. And so, when we get into sort of maybe the controversy later in this podcast in part 2, maybe we're just arguing about sort of two sides of one story. But, we've all got different tools, but ultimately you need to add them together potentially.
Yeah, the way it works. So I'm a good person to ask because I'm a maximalist for improvement on the face, period. I know how to get it. I may not do it. I know how to get it because I've introduced myself to every type of surgery that I've ever heard of. I try to learn about it. I do surgery. I'm in all planes of the face. So I know the face from inside to out. I do a lot of injections. I know injections better than almost anybody for teaching. If you ever, listen to how I teach about it, you'll hear things you haven't heard before and you'll understand fillers in a way that you haven't understood before. And on top of that, I am scared of everything. So that's where I have this kind of ability where most people don't have because and this is only in the soft tissue world. And then you understand that in the soft tissue world, I tell people you can't play Mr. Potato Head, meaning you can't take this person's anatomy and say a 13 millimeter lip is good and put on that person's face. You can't do it. The only people who work outside of our realm are the orthognathic and orthodontic and oral prosthetics and those kind of things. And so that becomes a different conversation where you can play Mr. Potato Head a little. You can actually change someone's physical structure. And it's a whole nother ballgame. But I'm aware of that realm too. So because I do a lot of teaching in that world and I go to a lot of conferences and lectures just to learn and understand about facial strain and facial positioning and the way muscles relearn and crazy things can happen with just dental orthopedics, they call it. And it's pretty impressive. But either way, from but I'm fairly unique in that sense. And I understand both sides because I'm in the middle of it. And I see the surgeons and they are only worried about surgery because that's all they have to deal with. And you see the injectors and they only worry about injectables because that's all they can do. And that's the way they see things. And see things from the outside with an ultrasound. And the surgeon sees things from the inside, not even looking at the outside. So you have both these realms. And in most cases, they're both wrong. So it's not that they're both right. That's like a very, it's a very polite assumption. In most cases, and if you sit me down with two people with differing views, I'll tell you, no, they're both wrong. And I'll give you very concrete reasons why. And my reasons will make more sense. And I don't mean to sound arrogant about it. It's just I have both sides and I see both sides. And I'm very open to both sides. So I'm not somebody who says all fillers are bad. You can't do fillers. I like doing fillers. I just say you got to learn how to do it. I'm not somebody who says biostimulators are all bad. I know how to use them, but they have specific uses. And I know the downsides. And I can tell you, what it's going to do to tissue rigidity and those kind of things in the future. And I'm not getting somebody who's going to say surgery is benign because surgery has massive risks. So it's like none of these things are benign. And I'm the one who's scared more than anyone of everything. So I'm a good person to throw in the middle of all these arguments that go on and on where people say, oh, we just have different viewpoints. And I say, well, both your viewpoints are terrible. And here's why. Most of the time, people are able to see it because otherwise I don't open my mouth.
You raise an interesting point around orthodontics and people that do facial surgery on that sort of from a different perspective. And there's a lot of discussions. Jake and I did a podcast recently about some trends like things like mewing. People get these like jaw exercises now. I know that when I had orthodontics done 20 years ago that I had too many teeth. I had teeth removed. Rather than expanding my palate, the teeth were removed to accommodate. And then you look at the sort of food we're eating and all those kinds of things. Do you think that there is a case to be made that there are elements in terms of the way that we approach treating people from an orthodontic perspective, the way that the foods we eat are having an impact on the shape of our faces and the way that we're potentially aging, especially as we sort of move into those later years?
Yeah, there is for people with imbalance. So people who have like a perfectly balanced skeletal and muscular architecture, meaning it sits well and there's no strain on different sides, whether it's asymmetric strain, downward or upward strain, then those people are fine. But then you have those who have the teeth or the jaw in a slightly reverted position or something like that. And then they have a chronic strain on their mandible that's making their jaw get smaller from all sides. And then you reposition their teeth and you see that it actually starts to move forward. So there's crazy changes that can happen within that world, just within orthodontic, not with surgery. Yeah. And then in some cases you add on surgery and it's really impressive. As far as training the face, there are things that can be done for behavioral training of the face. It's just extremely difficult patient compliance. So there are ways to erase resting bitch face. There are ways to get somebody to relax forehead wrinkles. There are ways to decrease temporalis hypertrophy. There's ways to do all that. It just takes a lot of behavioral training, and most people are not willing to go through it. And I don't think most practitioners know how to train them to go through it.
Are you talking about facial yoga in layman's terms? Or are you talking about
not facial yoga, but behavioral retraining. So if somebody is constantly scowling, they have to start to learn the feel of the down pull, whether it's here or here. Yeah. And when they feel it, they have to recognize where it's coming from. The problem becomes, what if somebody is clenching in their teeth, clenching while they sleep? And when you clench your masseter, your DAOs have a tendency to pull down too. And you end up getting this depressor worsening your entire life. So those things are hard to change.
Do you think that mewing works, or do you think it's a scam and a fad that doesn't have any real science behind it?
It can work a little bit. Yeah, there's no reason it doesn't work. Certainly, you can use it for physical therapy. So it is something that can be used. I don't, believe a lot of the before and after photos I see about it. Yeah. But yes, certainly it can be used. And if you see even somebody who has like even a slightly open bite and they've got a incredible facial asymmetry from it, if you're able to retrain yourself, even with an open bite, to come back a little bit, then your facial asymmetry can improve. There's other types of facial strain that happen with these things that we don't fully they just kind of affect each other.
Yeah.
I'm a huge proponent. I mean, I'm wearing Invisalign. I've taken them out for this podcast, but my facial symmetry has improved hugely just moving some teeth a couple of millimeters here and there. So it definitely works. And it's a good point. I don't think we should teach injectors to be dentists, but just have a cursory look at your patient's teeth and their bite. And if it just looks off or it doesn't sit symmetrically or you've got rotated teeth, you need to send them to a dentist for sure.
So two of the easiest pickups I tell for people learning is if somebody's got uncontrolled, just like bad skin and hives and reactivity and allergies, you look at their GI system, you ask them about that. If somebody has got massive facial asymmetries or asymmetries that are bothering them, take a look at their jaw and have them take a bite down and look at that.
Yeah.
Now we're having a course actually August 11th over here, which is going to be the Perioral Beauty Symposium. And it's about everything perioral. And we're going to go over facial flow instead of facial symmetry, which is, bullshit facial symmetry. So facial flow and looking at skeletal muscular balance. We're going to look at orthodontic, orthodontic, cosmetic dentistry, and then perioral stuff that you can do with injectables, true biostimulators like nanofat PRP, the gentle stimulators,
Controversial.
and surgery as well.
Yeah. So collagen has become the buzzword, or it's been the buzzword for the last few years, particularly here in Australia. Everyone's obsessed with it. We're taking collagen supplements. We're trying to do everything we can to stimulate it in the face. So obviously as we age, collagen depletes. It's sort of continuing to deplete over time. I think I read once you hit your teens, it almost starts to reduce by a certain percentage every year. So can we just revisit that a little bit and explain, what is collagen? There's, type 1, there's type 3, elastin's kind of thrown in there a little bit as well, and, the relationship between those two. Can you just give us a little bit of a cursory understanding of collagen and the important role it plays in this process of aging?
Collagen it's a structural protein, and you have about 29 types. We focus on 5 of them just because we can't talk about 29. It's very difficult. The main thing to know about collagen is it's not the only thing, it's not the last thing, it's not the final thing, and it's one element of many things. And it falls within this world of structural rigidity of dermis, but is also found in all other tissues. In different arrays. And you have also elastin, you also have hyaluronic acid, you also have desmin, vimentin, connective tissue proteins that you need to worry about also. So collagen is just one of a million things. Now, the problem with collagen in our world is that collagen is a macro thing, and people treat it like a micro thing. So collagen under a microscope is meaningless because it's a fibril. So it doesn't mean anything when you see collagen somewhere. Yet every study that we have focuses on this micro observation, but it has nothing to do with the whole. So the macro is what matters. Okay. You could have like a little black speck on a microscope and you can zoom out and it could be a piece of shit. Or you could have a black speck on a microscope and you zoom out and it's a rubber of a tire. Or you could have a black speck and you zoom out and it's your sweater. Okay. Or your headphones. So that's how collagen is. And I'm giving you these examples because the micro can be almost identical, depending if you know how to look at it or not. And then the macro is something entirely different. Right. So collagen is confusing for that reason, where people can damage your face, deposit a bunch of scar tissue in your face and do all this stuff. And if you go cut it on a cross section and you do H&E stain, it's going to turn out pink and you're going to see more collagen was deposited there. Yet if somebody who knows how to read a book will look at it and say, oh, my friend, this is scar tissue collagen. This is not restoration of your dermal collagen, which is what was lost. This is not the way that one type collagen was or type 3 collagen was. It's a completely different array. It's entirely different, and it's no longer considered something healthy. It's considered something unhealthy because it's not dermal collagen restoration. So collagen is necessary for our connective tissue structure and rigidity. However, it comes in so many different forms. Don't believe what you hear when people say collagen deposition, because collagen deposition could be cancer. It could be very easily cancer. It could be a tumor. It could be a keloid. It could be a million bad things. It could be a million good things. So collagen by itself, when people say that, is not necessarily good. And it's confusing to me when somebody says, oh, it's going to put collagen in your lips. Like, I'm like thinking like, what what I understand the idea of collagen is like a vitamin to these people. And then, but I'm like, what macro element are you seeing here that's going to be healthy for your lips? What are we looking at? Like structurally, if we open it and we look at the lip, what are you talking about? Is it hydration? No, that's not collagen. Is it cushiony gelatinous tissue? No, it's not, not collagen. So overall, for the listeners, just to understand whether you're medical or non-medical, collagen is necessary to live and survive. However, collagen is a little tiny tissue element which can look like a million different things once you stand back and actually take a look at it. So don't think all collagen is good.
Yeah, that's a good summary. And I think us injectors are guilty of probably using the word too loosely as one thing. But like you said, there's many types of collagen. And, my real basic understanding of the extracellular matrix, which is like the C that the skin sort of encloses, it's got collagen type 1, which is like these long steel pylons, if you like, they're more structural. And then you've got type 3, which are more connectors between the collagen type 1 pieces. And then you've got other types of things like hyaluronic acid, like proteoglycans, like all the other things that you mentioned that sort of like the soup in between the collagen. And so to just say, I'm going to make collagen is a bit simplistic. Like it's a bit more involved than that. And like you say, the organization of those collagen pieces depends on, well, is it natural? Is it innate? Or did you put a scarring type product in there to make collagen, almost like a scar tissue? Or did you put a thread? Or did you use an energy device? It's all different. And I think we talk about it a bit too loosely. And, we've done a couple of podcasts on regenerative medicine where we're now trying to understand all of this stuff in much more detail. And I think we'll realize that, even the various biostimulators and exosomes and the other things that are coming, they all do different things in that extracellular matrix. It's not one blanket effect.
It's like just a generic term that's been to describe putting more volume in the face, where it's a lot more complex. It's just been, that's the word that people have associated with all these extra things that they're probably not aware of.
Yeah. But, from a surgeon's perspective, when you look at someone's face, they're a bit deflated, sun damaged, whatever, and they're there for a facelift consult. What are you actually saying to them about their skin quality versus, sag? Because, of course, you can reposition the face, but what are you going to say to them about their skin quality and what are you going to do about that?
Well, so there's outer skin quality, which we're talking about dermis, dermis and epidermis, and then there's inner soft tissue quality and volume. So those are two entirely different things. And same as when we're talking about what's happening with radio frequency or sublative laser, erbium glass going in and denaturing collagen so it reforms as opposed to a stimulator placed under the dermis, which actually is fibroblasts coming in and depositing granulation tissue. So there are two very different things in two very different areas. And people confuse them because, again, they can't read the microscopic slide. So the dermatologists, for example, who do like the injections, they're like, no, there's evidence that shows that collagen is deposited there, but it's actually not dermal collagen restoration because it looks different. But either way, when I'm looking at the face, I look at it as the dermis as its own thing, even though it's not, but I look at it as its own thing because there's certain treatments for dermis versus subdermal fascia, which is a super important layer that's in the face.
Yep.
And that's layer 2 of the face. That's the layer that's in between most of our mimetic muscles and the dermis.
Yes.
And then there's your mimetic muscles. And then there's what's under that. So the most important unit that you have here for skin coloration, for skin hydration, for skin reflection, translucency, everything you can say about skin overall and skin support is actually not one of any of those things. It's all three of those things: the mimetic muscle, the subdermal fascia, and the dermis all together. And in my mind, I'm trying to get this healthier for them. And the things that I'm looking at is the muscle, I want it functioning properly. And that's achieved by proper volume on top of the muscle and proper position of the muscle. I want the color of the skin to be good and reflect light beautifully, for them to be brilliant and bright. And that comes from the thickness of this subdermal layer because light scatters through it. So I always think about the translucency of that. And then I think about the dermis on top, which is going to have the pores, the rhytids, and anything else. And just so you know, the pores and the rhytids occur first from deflation of this layer of that. fat fascial layer. It doesn't happen from dermal issues. It happens primarily from that subdermal fat fascial layer. Then you get dermal problems. So long story short, when I'm talking to the patient about this, I tell them, I want to do a little bit of volume restoration in your face if I need to. And this is if I'm going surgical. And I do that with a little bit of fat grafting sometimes. And then I stimulate this layer to hydrate itself because I don't want to add more volume. So I can actually use nanofat or nanofat and PRP in a way that without adding volume to your lips and your philtrum and your subdermal fascia, it'll thicken itself. And that's from deposition of unknown things. So I don't give it a name of collagen. There's hyaluronic acid, collagen, elastin, fascial tissue. There's all this other stuff that'll inflate, color correct, support the skin. And then now it becomes easier for me to treat the dermis and the epidermis. So then I go and I say, okay, we can do radio frequency lasers, whatever we need to do. But I have that conversation with them in a facelift consult. If I'm not having a facelift consult, somebody's there for non-invasive stuff, I go much more simplistic.
Right.
Perfect.
Okay, so talking about facelifts, what is your surgical approach in terms of like what plane are you focusing on? What structures do you cut? Do you cut out or cut? Where do the stitches go? What's preserved, etc.? Can you just walk us through your approach to the facelift process?
Yeah, so I operate in a realm of what's called deep plane, but deep plane is a bit confusing amongst surgeons because what was classically described as a deep plane is different than an anatomic deep plane. And there's been a million other descriptions of a deep plane. But what I do is I release these soft tissues maximally. So I'm not a skin surgeon. I'm not doing a bunch of skin pulling, skin this and that. I'm not doing that. So I do my fat grafting first. I get everything in proper position and with proper support, make sure the volume's correct. And then I go make incisions around the hairline, into the ear, behind the ear. And I release here in what I call a surgical deep plane, which is different than the anatomic deep plane. So the anatomic deep plane, if you look at all the muscles in the face, on the underside, they're gliding. They don't have attachments so much, except for on tethering points. And then on top of them, they're connected to the subdermal fascia and the skin is one unit, right? So that's how mimetic muscles work. So I go under that, under the platysma over here, and then I go over the zygomaticus over here, meaning the subdermal fascia is up for all of this. And then I connect them over the buccal space. So this is what allows me to get maximal soft tissue movement. And that's why my patients look natural. I don't have to pull at that point. I've released everything. And when you're laying somebody back, the tissues actually just gravitate into where they want to be, which is just like your hand takes it about 70%, 70 degrees in the vertical for most people, not everybody. And it just falls back. I stitch it down. And in the neck, I'm doing magic now. So in the neck, I've done some like very cool things where I can actually restore the vectors of the platysma where they they turn like this with age and you see it kind of goes vertically down. I can actually rotate it and I can rotate it and provide depth in the neck. So your jaw actually goes back in a little bit and the neck goes in a lot. And so three-dimensionally become much more defined, more delicate, and you get definition of everything. And that's just by putting the muscle back into the front of this bone. I created this technique called the mastoid crevasse, which I gave it a funny name to hope, that it would catch on and people would repeat it. And they have. And that's how I do the lift. And when you look at my lifts, there's no pulling, there's no stretching, there's nothing in terms of like that weird kind of look because I don't do those things. I don't stretch anybody. I don't pull anybody. And for surgeons, it was difficult to understand how you get these massive skin quality improvements, massive, without pulling on the skin. And so I try to explain to them, you're looking in the wrong place. You're doing it the wrong way. And so we're changing the paradigm, hopefully now, where most surgeons are understanding concepts of proper contouring, volumization, and creating more surface area for skin to travel. Because as you age, the surface area gets blunt, and then you end up with wrinkly skin because it doesn't follow these contours anymore. So this is the new paradigm.
So just so I'm clear, so you obviously make your incision around the ear and the hairline. It sounded like you're in the sort of superficial fat layer closer to the zygomatic bone, but beneath the buccal fat pad, you're under the platysma. But then you've already refilled prior to surgery with fat, did you say?
Yes. Yeah. So I do my fat grafting beforehand, and I do it in a very different way than most people do.
And so when do you do that?
At the very beginning of the surgery.
Oh, right, in surgery.
Yeah. So most people were taught by visualization. So if you learn from any injector or any surgeon, they kind of show you, okay, I do this, you do this, and you just follow with your eyes. And half the surgery that I do is not by visualization at all. I joke about it sometimes saying I could do it with my eyes closed, but legitimately I can do it with my eyes closed. So my suspension, I'm feeling for it. I'm not even looking at it. My brow suspension, I'm feeling for it. I'm not looking at it. My fat grafting is similar, where I visualize the fat grafting that needs to be done with the patient sitting in an upright position.
Yeah.
And that's for the gravitational effect.
Of course.
But then I actually inject them laying down. So now I have to feel everything. And what I do is I turn them this way to have the skin collapse on this side of the face. And I inject there by palpation, and I can feel the layers that are deflated, because we don't all deflate the same on each side. And this is where a lot of the confusion comes in fat grafting. People just go fill the face. They don't understand that you actually have specific deficits. People have very, very unique specific deficits on different parts of their face. It doesn't change the same on both sides, and not from person to person. Your face, I can see the changes more on the left side than the right side. And you can see, and if I were to lay you down on this side, then this side collapses and this side anti-collapses. So you can't feel this side. You can only feel this side because I can feel all the depressions on it.
Yeah.
And then I lay them on their back, and then I can feel the depressions on the front.
Okay, so you sort of fill them on the table with nanofat and made PRP, and then you don't cut any of the ligaments?
So this is a whole lecture in itself. Okay, when people hear me lecture, they say one thing in different ways, which is nobody's ever explained it to me that way before, and it makes so much sense. Now I understand why I never understood it.
Okay. Just for layman's terms, just so the listeners would, have an idea of what a facelift involves.
Almost everything we're taught is wrong. So one of those things is the retaining ligaments. The retaining ligaments, you'd have to think about them. Number one is misunderstood. And then in some cases, as an obstacle that needs to be released. But they don't actually retain anything. And in many cases, like the mandibular ligament, which is this pregial sulcus area, is thought of as a facial retaining ligament. However, I just published a study, which is coming out in ASJ this month, that shows that it's not. And actually, it's a deflated area that collapses and looks like it's tethered, but it's not. And my argument was, why are you having so much difficulty with this area when a 5-year-old has the same ligament and it doesn't look bad? And a 10-year-old has the same ligament, 20, they all have the same ligament. It doesn't contract, it's there. It's not even an osteocutaneous ligament, it's under the muscle. So why is everyone having so much trouble with it? Why do they have inconsistent results? Why is it still dark with a flash light on it, even though a flash is hitting it? It's dark because it's missing yellow under the skin because it's a fat depressed area. So there's areas like that where we actually fix by lipofilling half a cc and it completely goes away. So as far as do I release the ligaments, my answer becomes to these surgeons, your focus is in the wrong place. You're not understanding the anatomy correctly. You do have to release decussation zones, and that's more important. And it's the same idea. It's the same idea, but it's broader. So there's no magical medication, basically. There's no magic potion where you get in there and you flick the zygomatico-cutaneous ligament and the face goes up. It doesn't exist. So it's harmful to think about it that way. However, and actually I can explain what that whole area is. But when you think about it more as it's a decussation zone between fascia and muscle, where you have cruciate fibers and you have to release that entire area in order to get it to rotate, now you're going to start feeling the proper release. And no longer is it a mystery to you why your surgery has failed when you went into a superficial plane and cut the zygomatico-cutaneous ligaments, or you went into a bony plane and cut the zygomatico-cutaneous, whereas I went into that middle plane and cut it, but I got the result. So you start to realize that we're just trying to mobilize soft tissues, and there isn't one magic ligament. You have to release the entire zone of soft tissue. And the same thing goes with the conjoint tendon for doing brow lifting. You have to release it all the way up, all the way to the back to allow the mobilization of that entire decussation line of fascia to muscle to fascia to muscle. And then that way you get the change.
Yeah, if anyone's actually really interested, I've seen you do a big monologue on your Instagram about ligaments, so people can go and listen to the whole thing if they want.
So you're a plastic surgeon. Obviously, you spend most of your time sort of in the OR or consulting patients. So can you just talk to us a little bit about your injecting experience, like how much of it do you actually do versus maybe people that you've employed within your practice? Just give us a little bit of a background into that side of things.
And actually, how did you train? Who taught you?
Yeah, good question.
For injectables or surgery?
Injectables.
Injectables, yeah.
Injectables, I learned mainly by myself. I was trained by Andrew Giacono, who did a fair deal of injectables back then, but he wasn't huge into volumizing people. He was really focused at that time in his life on getting away from fat grafting and volume and seeing what can be achieved with true mid-face lifting through a deep plane. So I was there at a time where he wasn't doing as much. And when I went into practice myself, I turned out to be good at it. And so I got popular very quickly amongst young model patients. So there was this group of just really good looking people in LA who started coming to me, and it expanded pretty rapidly to a lot of the actors, actresses, singers, everything in the area. And it came from that I got good at understanding kind of everything as far as facial aging goes, because you deal with 20 to 40 people a day rather than 1 to 2. And not only that, I listen to everybody. So as much as skeptical as I sound, I really listen to what every single person says, because I'll pick something up. So a patient can come in and they'll give me stories about this person did this person did that. So I had the experience of 20 injections on one person. I already knew from that person's face what had gone wrong. And I learned very quickly how to avoid things. And it kind of escalated from there. And then mixing it with surgery, I just got better and better. So I was the busiest injector for sure for one of the companies here. I think it was Galderma. As a single person, I was injecting more than 5-person derm practices. So because I was doing 20 to 40 people a day, and most surgeons, don't get 20, 40 a day. That's on top of surgery. And these are full injection, laser, doing all that kind of stuff. So I did tons and tons and tons. The amount of volume I inject on people actually decreased substantially with time, because I became much more efficient with it. And I learned how to do color correction, muscular correction. I learned how to treat smile lines, complex things that most people don't really look at, zygomaticus indentations, things like that, where with one cc, maybe 2 cc's, I was able to achieve on a face what I used to achieve with 5 cc's. And I do feel as though you preserve somebody long term a little bit better doing less volume, little tiny bits, kind of fix whatever is needed.
Fantastic. Well, we're going to end there for part 1 of this conversation. So if you're interested in part 2, you're welcome to join our Patreon.
Yeah. And what are we going to be talking about in part 2, just to sort of remind people, what are the main meat of the topic?
Yeah, look, we've sort of deliberately dangled this topic, but Ben's been pretty vocal on his Instagram a couple of times about what he feels is the implications of using particularly biostimulators in the face, and why he thinks that could be potentially negative, especially when you're considering face surgery or facelifting surgery. So part 2, if you're interested in that, tune in. Yeah,
particularly interesting because we're going to cover this when we start this next part of the discussion, but there has been a decrease in dermal fillers across the world, I think, in most people's practices, and it has been replaced with biostimulators. So I think this is a really relevant topic to be talking about at this point in time.
Would you like a cliffhanger for the next
episode? Yes, please. Yeah, bring it.
So big pharma companies send cease and desist letters to people like me when we talk about this stuff, threatening to sue us when we talk about it. So just realize I will be limited in what I'm saying because I don't feel like getting sued by these people. However, they're trying to silence doctors from speaking of their experiences. So this is a real thing that's happening. It's not just to me. There are many other surgeons who are in group chats talking about a few specific companies who have been doing this, trying to silence, and they've been promoting things against FDA indications purposefully. So I will be limited in what I say, but I will give my maximum insight. So if and when they ever do sue me for speaking, the truth about this stuff and warning and trying to keep people healthy, and I'm pretty much helping promote best practices, I'll give them nothing to use against me.
Well, thanks for being candid and open. We will see you guys in part 2. Thanks, Ben. We appreciate that. See you later.
Hey guys, just a reminder that part 2 of this podcast is available now on Spotify. To access this and all of our future subscriber-only episodes, please sign up to our Patreon. You'll find all the information on how to do that in the podcast description below.
For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.